Bismillahirrahmanirrahim. My name is Dr. Kamran Shaikh. I'm a consultant psychiatrist. So let's continue with the long-acting injection and prescribing in psychiatry. So our topic today is about prescribing of long-acting injections, and it is inspired by the Maudsley Prescribing Guidelines. So what we know about long-acting injections is that they are better than orals in some respects because it is better compliance and it is few relapses, less hospitalizations. So rehospitalization is a bit low. Compliance is ensured, and the follow-up and monitoring of the mental state is quite ensured, that you can monitor the mental state. Because whenever you are giving depot, the nurse who is giving the depot is going to see the patient. And if it is every 15 days, then the nurse is seeing the patient every 15 days. And patient is coming to the outpatients department every 15 days or maximum every month. And or maximum if there is a 3-monthly depot injection, which is only one, which is paliperidone, then 3-monthly follow-up. But then again, the downside of 3-monthly is that the patient has gone for 3 months and you are not able to monitor his mental state for the full 3 months. So, but monthly injections, they are ideal. So in the United States, the long-acting injections are given even for first episode psychosis, and many patients accept it. But there is a difference between giving for first episode psychosis and giving it for the drug naive patients. So you can give first episode psychosis patients, but the first drug must be some oral medication. So you give oral medication first, and then you see the response, and then you can give it even in the first episode psychosis, but after trying with the orals. So if in the US they are giving LAIs in the first episode psychosis, that doesn't mean that they are giving to the drug naive patients. They are giving to the patients who have tried the oral medication first. But the clinicians are showing some reluctance about giving this as an oral. So they say that patient is taking oral, why inject? And then there is a risk of long-lived side effects with the injectables. So that means, can we give this these injections to the to the patients who are accepting oral medication? So yes, we can. Ideally, mostly we give it to the patients who are non-compliant, but sometimes to ensure compliance and and in the best interest of the patient, for the well-being of the patient, we can give in the patients who are accepting the oral treatment, as long as they also accept the injectable. So let's go to the indications then. So the indications are, number one is patient's preference. So if the patient is preferring the injectable, we can still, we can go ahead with the injectables. And then the risk of non-adherence. So these are the main two indications. If the patient prefers, then go with injectables, even if they are accepting the orals. And I have some patients who accept both injectables and orals, but we said to them that it's preferably something which is to be given, like the injectable is preferable for them. So that's why. So the first generation antipsychotics, long acting injections. So with the first injection, we give test dose. And why we give test dose? Because first of all, there is a risk of severe extrapyramidal symptoms, dystonic reactions, neuroleptic malignant syndrome. The second reason of giving the test dose is because of the sensitivity, allergic reaction to the oil base. So the first generation antipsychotics are mainly oil based. So when we see the oil base, that can react, and that's why we give a very small dose to see if there is a reaction, allergic reaction, sensitivity reaction to the oil or not. If there is none, then we can give the full dose next time after 1 week. Now, an interesting question: can we give second generation antipsychotic test dose? So up till I read this in the Maudsley Prescribing Guidelines yesterday, I was also of the opinion that we cannot give test dose in second generation antipsychotics. The reality is, yes, we can. We can if the patient is refusing everything, refusing the patient is refusing the oral medication, and there is no way he's going to take the oral medication even for a few weeks. In that case, we may try the test dose. And I remember when I was a registrar many years ago, so my consultant then, like we use paliperidone in the UK and Ireland. So paliperidone, usually it is given as 150 milligrams loading dose, and then 100 milligrams test dose, 100 milligrams maintenance dose after 1 week. So, but my consultant made it the other way around because he wanted to use it as a test dose. It was the very first time the patient was receiving. So it is consultant's discretion. So we can give the paliperidone as 50 milligrams test dose, for example, and then after that we can increase it to the 100 milligrams and then 150 milligrams. Usually, with all the second generation antipsychotics, you give oral and first, and then you establish the patient on oral, then give the loading dose, which is usually greater than the maintenance dose, and then the original dose, because they are more polymer based or solvent based, but not oil based, the second generation antipsychotic depot injections. And I hope that inshallah they will be available in Pakistan and India as well someday. So it's important to know about those second generation antipsychotics. So things do come to our part of the world, but sometimes it is delayed a little bit. So don't think that, if you're working, practicing in Pakistan, you don't need to know. It is good to know about these things. So test dose is not necessary for second generation and not routinely given, not licensed, but sometimes you can give it. So second generation antipsychotics, the base is not allergenic, and it is better to give the loading dose. And even before the loading dose, you give the oral trial first and then the loading dose. So in exceptional cases, test dose, the loading dose, I mean, you give the test dose. For example, you have given the test dose of paliperidone as 50 milligrams as a test dose, or 25 milligrams. Then you see that the patient hasn't shown any anaphylactic reaction or anything, or any sensitivity. Then you can use it, depending on the previous history. You can use the loading dose as 150 milligrams first, and then 100 milligrams after 1 week. Start low and go slow, especially for the first generation antipsychotics. So haloperidol and the zooklopentixol, flupentixol, flufenazine. So these three are available in Pakistan: flupentixol, zooklopentixol, and flufenazine. So the principle is the same: start low and maintain on the lowest effective dose. Now there is another question that I mean, what is the, should we keep the interval? Should we decrease the interval, or should we increase the dose? So the answer is provide maximum possible interval. So usually for the second generation antipsychotics, the intervals are usually every 4 weeks, monthly. So we can try the same. We can try the same in the first generation antipsychotics as well. Leave it for 3 weeks if possible, or otherwise 2 weeks. Don't give weekly from the very beginning. So I usually start at every 2 weeks, but now after reading these guidelines, I may reflect on my practice and I may go with the 3 weekly option, because that is the maximum possible interval. And the maximum is not even 3 weeks, the maximum is 4 weeks. So I may consider it as well at some time, but usually we give it 3 weeks for first generation. So stick with 3 weeks, and if the patient is accepting, they're not showing any signs of relapse, they're not showing any side effects, then you can even increase it to 4 weeks. And that's what I intend to do for one of my patients, that I want to increase that to 4 weeks, because it is within the license and it is within the prescribing guidelines. What is the advantage of increasing the interval? So if we are giving it at an increased interval, then the advantage is that there are less pricking, and stable plasma levels are also delayed with the long-acting injections. So response can be slow clinically. That's the downside. But the less pricking, it's very important, because these oil bases are very painful. If you have received any injection of, for example, Neurobion, like a multivitamin injection at some time, you can know that it can be painful at the injection site. So these injections are painful, especially for even after the injection. And then there can be cellulitis, and it hurts after the injection. And then there can be, bruise-like picture. So that's why it is important to rotate from time to time. So not the same time, give it nearby, but at some other site. And then the next time you should change the sides. So from right sides, left side, left, right, left. And when you come back to the left, after having given to the right, give it at a different site, so that it doesn't hurt again. and it doesn't cause any pain or cellulitis, etc. So which ones are oil-based? First or second generation? So first generation antipsychotics are nearly all oil-based, and I can name those: haloperidol, zooclopentixol, flupentixol, and flufenazine, and pipothiazine. So these are all oil-based. So steady state is generally achieved in 6 to 8 weeks, but then that is different from drug to drug. It can vary from drug to drug, but generally 6 to 8 weeks, because many people ask this question: when is the steady state achieved? So on average, it is achieved in 6 to 8 weeks. But when you go to the table in the Maudsley Prescribing Guidelines, one of the tables, I think the table on the page number 72 and the current edition, it can say the time to peak, and then the plasma half-life, and then time to steady state. So I can't share that on the screen, but I can tell you that aripiprazole time to steady state can be 20 weeks for aripiprazole, and similarly, it can be for flupentixol 8 to 12 weeks, flufenazine 8 weeks, and then or 8 to 14 weeks. And then I think they say about the haloperidol about 14 weeks, olanzapine 12 weeks, paliperidone 20 weeks, and paliperidone 3 monthly 52 weeks. And then risperidone 8 weeks, zooclopentixol 12 weeks. So that is the steady states. But like that is the time to steady states. But usually you can have some steady state in at least 6 to 8 weeks. But you can still have some more response, and more steady state can still be achieved, the maximum steady state, even after that. So what does that mean is that you don't have to increase the dose, quite quickly in this. Be slow in increasing the dose in the first 6 to 8 weeks. Go to the optimum level. I won't say that keep it at 25 milligrams of zooclopentixol, or 100 milligrams of zooclopentixol, 20 milligrams of flupentixol. Go to the optimum level, which you see the response in most of the patient, or in that patient where you are expecting the response. So normally I go to 200 or 250 of zooclopentixol, and then I wait for 6 to 8 weeks, and then I go further up if required. So you go to the optimum dose, but don't go with further increase. Again, you have to tailor the response according to the patient's like the physical state and the mental state. So each patient is different from the other patient. So increase it in dose makes more sense if it is after 6 weeks. So before 6 weeks, you don't keep it to the minimum, but you keep it to the optimum. Like the minimum effective, you can say, you can keep it to the minimum effective expected in that patient. So it can be about 200 to 250 milligrams of zooclopentixol every 2 to 3 weeks. So after 2 or 3 injections of depot, then you can plan the further dose increase. So you keep the dose the same for the first 2 to 3 injections, depending on if they are 2 weekly or 3 weekly. Antipsychotic naive, which we sometimes say drug naive patients, mean antipsychotic naive patients should take oral medication first and then injectable. Although you can give injectable in the first episode psychosis, but try orals first. Check the response. And Zuclopentixol, the first ever the first ever antipsychotic of life must be oral. That's what I would say. So, but Zuclopentixol we can give as, the traditional antipsychotics can be given even the very first dose as injectable, but that doesn't mean that they are antipsychotic naive. No, they must have taken haloperidol or Zuclopentixol oral or flupentixol oral or risperidone oral or olanzapine oral, something they have taken in the past, and then after they have taken something in the past, then if you are introducing a new drug such as Zuclopentixol, you can give it in injectable as a test dose from the very first time. So that's what I'm trying to say. As long as the patient is not completely antipsychotic naive, you can give the very first dose of Zuclopentixol or traditional depots as the very first dose of that particular drug. Aripiprazole is 300 to 400 milligrams, so we are just going to the doses. Flupentixol, we give 50 milligrams every 4 weeks to 400 milligrams weekly. So 50 milligrams every 4 weeks we can give. And then haloperidol, 25 milligrams test dose. So 25 milligrams, the test dose for haloperidol, and then 50 milligrams every 4 weeks to 300 milligrams every 4 weeks. Previously, when we were in the training, haloperidol was mostly given after every 2 weeks. But now the trend is 4 weeks. So keep the interval the same and increase the dose. But sometimes I think some of the formularies allow us to give it every 2 weeks, but it's better 4 weeks. Zuclopentixol usually start at 200 milligrams every 3 weeks, 250 milligrams every 3 weeks, and then maximum you can go up to 600 milligrams every week. And Zuclopentixol patients usually accept it well. And I've this is substantiated by my own clinical practice as well, because of the antihistamine effect. So that's why most of the clinicians in the UK and Ireland, they still prefer Zuclopentixol. And I'm sure that Zuclopentixol is one of the favorites in Pakistan as well. Fluphenazine. Now, unfortunately, fluphenazine is no more available in the UK and Ireland, but we should still know. And it is still available in other countries. It's still being widely given in Pakistan. So 12.5 milligrams test dose. And usually patients are 50 milligrams every 2 weeks, and sometimes up to 100 milligrams every 2 weeks. But again, you can go every 5 weeks as well, every 3 weeks, every 4 weeks, even up to every 5 weeks. So 2 weeks is not something hard and fast. Paliperidone loading dose required at now the second generation, we give loading dose first, although we can give the test dose of 50 milligrams if required. But usually we go with the loading doses. So 150 milligrams loading dose, And then after 1 week, we give 100 milligrams. And then minimum can be 50 milligrams monthly. Trevicta, paliperidone 3 monthly injection. Now we have very, very few patients on it. And although it is researched, it's well researched at this stage, but it's not very much common in clinical practice. So I may have 1 or 2 patients on it, but we need to know that whether they are getting any long-term side effects from these 3 monthly injection, or the other is the risk of relapse. So risk of relapse is much higher. I've been told by some of the colleagues that the patients may relapse within 3 months. So you have to keep the dose quite adequate, but even then, their levels may fall off within 3 months. So use it only in selected patients. Otherwise, stick with monthly if you can. And 3 monthly injection can only be given in after 4 1-monthly injections. So you give at least 4 of 1 monthly injections, and then you go with the 3 monthly injection. Now, routes of administration. So gluteal or buttock by default for all, but paliperidone and risperidone deltoid route is preferable, but you can still give it in gluteal or buttock. Flupentixol, zuclopentixol, these 2 can be given at thigh as well. And when I was doing my senior registrar training, then I knew it in the UK that they used to give it at thigh. In Ireland, I think I've never seen, or I don't know if they are given at thigh. But in the UK, it is a common practice. If the patient doesn't prefer buttocks, then give it somewhere at the front of thigh. So the nurses are usually trained and they know which site. Olanzapine, a bit tricky. So 150 milligrams every 4 weeks to 300 milligrams every 2 weeks. That's the dose. But then there is a post-injection syndrome. The blood pressure may go up and down. There could be tachycardia, post-injection delirium, sedation. So that's why patient has to be observed for 3 hours in the outpatient's clinic, in the depot clinic. And the theory behind it is that when you're giving olanzapine, maybe part of that is absorbed through the blood vessels. So partial intravascular injection. Again, metabolic syndrome and weight gain will be problem with olanzapine. Similarly, there will be hyperprolactinemia with these 2, paliperidone and risperidone. Piportil. Has anybody heard the name of piportil or pipothiazine? So piportil or pipothiazine, it is a first generation antipsychotic, and I didn't know about it until I went to the UK for my higher training. And the sad news is that I only knew it when I only came to know it when it was being discontinued. So unfortunately, these 2 very effective drugs, fluphenazine and pipothiazine, these have been discontinued in the UK and Ireland as well. So piportil was a very good depot. Many patients were very stable on it, and suddenly, because there is less demand for it, or and then the cost is very low, the companies just suddenly discontinue it, and the patients sometimes get relapse, and sometimes this relapse, it cannot be covered by any other antipsychotics. So piportil was very good, but unfortunately it was discontinued around, I would say, 2017, 18, 19. Around that time, it was discontinued. So addition of concomitant oral antipsychotic, that is a possibility. You can still give some oral antipsychotic. The combinations which make sense is adding some aripiprazole along with what I say with risperidone, paliperidol injections, because to control the hyperprolactinemia. That can be something which can be considered. Similarly, oral aripiprazole with olanzapine just to reduce the weight gain with the olanzapine depot. So sometimes if the patient is not responding to a big enough dose, but again, you have to keep in mind, try not to go off 100% of the combined dose. So for example, 50% of olanzapine and 50% of aripiprazole makes 100%. So don't go above the 100% as a combined dose. Panfluoridol, I have seen 1 or 2 patients on it. I've never prescribed it, but I might have continued it in some of my patients. It is good enough. So you just need to know the name. If you come across somebody who is on Panfluoridol weekly injections from the past, and we have discussed that. Then the risperidone subcutaneous monthly injection. That is another thing, and we'll in the future lectures we will try to cover what is that Perseris in the US, what is that subcutaneous injection, and why is it used? Because we have never seen the UK or Ireland yet this subcutaneous injection, but that does exist, and we'll come to learn about it in the future talks. And I've told you already a few minutes ago that zuclopentixol is more tolerable due to anticholinergic effects and sedation. So that's it for today. Time for the questions before we wind up. Any questions? Please unmute your mic or put it in the chat box. Okay, so there's no questions, so I'm going to stop the recording. Which depots have more side effect of sedation, please? Okay, more side effects of sedation, obviously olanzapine, and the other one will be zuclopentixol, and to some extent haloperidol, because it's a very potent D2 blocker, although it doesn't have antihistaminic side effects. But even then, the thing is that haloperidol can be quite sedating. So these 3, I would say, are more sedating than others. All right, so thank you very much, and yeah, thank you very much. See you next time.